into these different components. And then we rehab each of those components so that the person can gain skills towards independence in that specific area. So there are some times that we are doing maybe exercises to help gain more strength physically to be able to perform the activity, or we do some cognitive skill building. But it's always activity based and very client centered for what they want to engage in, how they want to spend their time. So I want to tell you a little bit about my work experience. Like I said, I've been an OT for about 10 years. And for 8 of those years, I worked in various hospital settings. So I worked in the skilled nursing setting, the acute care setting. So when your loved one first has their injury and they go to the hospital, I worked with those types of clients. I also spent a lot of time working in acute rehab, which is where people really learn how to walk and dress themselves again right before they go home. So as I was working in these environments, a lot of my clients would go home and I just couldn't say goodbye to them. So I stayed in touch with them as they went home and transitioned back into the community. And a lot of those people would call me and say, hey, like I'm really struggling. I had 3 to 4 hours of therapy in the hospital, and then I transitioned home and I have almost nothing. I have maybe outpatient for a little bit, and then eventually I got dropped off. And so my clients would reach out and say, hey, I'm struggling. I'm not making as much progress as I was. And sometimes caregivers would reach out and say, oh my gosh, I'm so stressed. I can't handle this. I'm really lacking resources. And so when I was in the hospital, we started doing some research and figuring out, like interviewing caregivers, and it was just wild to me the percentage of caregivers that reported lacking resources. It was like something like 75%, which is just outrageous. So I started to really brainstorm ways that I could help a little bit more when it comes to reintegrating into the community and helping caregivers as well. So I ended up starting my own private practice so that I can provide extra therapy, right, for people at any phase of their recovery. So I have some clients that are 8 years post injury or 15 years post injury, and they're making tons of progress. It's amazing. So it just goes to show you that really rehab shouldn't stop. You should always have access to services. But of course, with the private practice, there are only a certain amount of people that I can help in a day. So I started this online resource where I can start to help more people. And that's called the Empowered Neuro Community, which I'm going to show you a little bit. I'm going to share my screen and show you. But that's extremely affordable, and people all over the world are inside. And I post therapy resources, and people have access to me at all times to help answer their questions. So I want to share my screen and show you just a little bit about what it looks like inside. And everybody that is here tonight gets free access to Empowered Neuro. So right after this, you can go log on, create your own account, and have access to me and all of this information. So inside the community, we have the ability that you can chat in the member chat, ask any questions that you have regarding your therapy. We also host some live events. So we have an upcoming event with a driving rehab specialist. That's going to be next week already. And it's kind of similar to this, where you can join, learn from the driving rehab specialist, and then answer questions. So any of the previous events that we've done with professionals in the neurology field, they're all recorded and in here. So you can learn from neuropsychologists or acupuncturists, all different professionals. And service dogs, that was one of my favorite ones. So then we also have therapy resources inside. So here's where I'm providing therapy resources like home exercise programs, some fine motor coordination activities and strengthening, so that you can continue doing that on your own at home. But the one section that I really want to share with you all is this therapeutic caregiving section. So of course, I care a lot about caregivers because what you're going through is such an identity change, right? You were not ready to experience becoming a caregiver. Nobody's ready for it. And it brings on, as you know, a lot of stress, and your life has to shift in a lot of ways financially and how you spend your time, right? And think about OTs. We focus on things that occupy your time. And for you guys, the way that you occupy your time is totally different now. And you were never trained to be a caregiver, right? So this is all new. And in order for you to have a good quality of life and your warrior, your loved one, to have a good quality of life, I want to try to help you both to improve. And so through these monthly series, these educational series, I want to try to help you to become a therapeutic caregiver, which really means understanding your loved one's deficits, how to improve them at home on your own, and also how to take care of yourself. So there's also a whole self-care section for you guys. And when we think about neuroplasticity, right? Meaning how it's a really hot topic in the field right now because we are finally understanding how much control we have over our brains, right? And especially with after a neurological injury, we have so much control over our ability to rewire connections. And so I'm always telling people that what you practice, you get good at. But when people leave the hospital, sometimes what they're practicing isn't necessarily the best thing for them, right? They could be practicing sitting on the couch watching TV. Right? If you're sitting on the couch watching TV, you're going to get good at that, right? And your muscles are going to get good at that. Your brain will get good at that. So what we want to do is foster practice that is appropriate for you and for your loved one. So if you can understand how to help your loved one practice the things that will benefit them, they will gain more independence. And for you as a caregiver, if you can practice techniques that will help you, like learning how to manage maybe your anxiety or your mental health, right? That's also part of neuroplasticity. So I want to try to help you the best I can to be able to care for your loved ones so that they can improve and also care for yourself. And so that takes a lot of practice and a lot of learning. But that's my goal, is to just be here to help you, because if they lose access to therapy services, but if you know how to really help them grow at home, you could be a good therapist, right? So I want to try to be here to help you. And that's going to look different for each of you, but I'm here to help guide you. So I would love to open it up to some questions that you might have specifically for me. But of course, then we can focus on maybe some topics that I can educate on for next time, so that you guys can have a little bit more guidance specific to you.
Hello. Okay, Jacki, so you are ready for questions. Okay, so what I see here is, okay, this might relate to you, also might be for Dr. Abrams. Any hints on bladder control other than frequent trips to the toilet?
So yeah, Dr. Abrams can probably add a little bit more on the medical side of things, but of course, frequent trips to the toilet can help. What I usually recommend as well is if they're happening at night, and again, I would connect with your doctor about this, but maybe limiting fluids a couple of hours before you go to bed, that could help in the middle of the night. And what you said, other than frequent trips to the toilet, but what I always recommend is getting on a solid toileting schedule, which typically means every 2 hours you're going to the bathroom, even if that means you don't have to go. You're just attempting to go. And then that will help at least with some accidents in between.
Yeah, I completely agree with you, Jacki. I might add that I think basically the idea of timed voidings is a good habit to get into. But I would emphasize that there are many pharmacological ways to deal with bladder issues that occur after, for example, TBIs, spinal cord injuries, and strokes. I think if I can't go through all the different medications because it runs all the way from certain classes of medications to things like Botox, which have been used to actually help to control certain kind of bladder problems. There are also um, um, medical devices such as sacral nerve stimulators that have been used. So there's a wide variety of ways to deal with this issue. Challenge for you is to find somebody who's aware of these and wants to help. And obviously, a urologist is one of the first place to start. But there are urologists that are specifically interested in neurourology, and locating one of these, which is there are people located, people that are at UCSF. There are people down at Stanford. I'm sure Kaiser has specialists in this area. So if there's a problem, don't just accept the fact that you can't deal with it with just say, for example, with time voidings. Consider the fact that if you locate the right specialist, there are many interventions that could potentially be helpful for you.
Okay, great. Thank you both. Another question is acupuncture a viable treatment after 3 years post-stroke?
I love that question. So acupuncture is something we just did a live event inside the community. So I really hope that you go and watch the recording. The acupuncturist talked a lot about this and how it can be helpful post-neurological injury. So I have clients that go and get acupuncture, and absolutely it can be helpful, but everybody has a different response to it. So what I would recommend is going to just try it. And some people, it's not designed to be painful, but some people don't enjoy the sensation. And so I wouldn't say that it's for everybody, but I would highly recommend trying it. And a lot of people like it, and they find that their sensation improves after. They find that they end up getting a little bit more mobility. So I would definitely recommend that in combination with other therapies, but it doesn't hurt to give it a shot.
Just a quick comment on that. It's a fascinating issue with acupuncture. I agree. I completely agree with everything Jacki said. I mean, it's not going to help everything. It's primarily best medical evidence is for treatment of pain. But I must admit, several years ago, I was in Shanghai as a visiting professor there, and I went up to a rehab unit at one of the Shanghai hospitals, and virtually everybody on the unit had needles in them, being used for their treatment of various kinds of neurological problems with acupuncture. I don't fully understand acupuncture, but I do agree with Jacki that there's certain people that get a lot of help from it. I think it's safe. And so my recommendation to people generally is give it a try, see if it's helpful. And if it's helpful, you're lucky. You have another thing to kind of help your loved one.
Yeah, having more options, because I agree with what both of you said from that perspective of there's different modalities, different therapies can work for different people. And that I thought that was a great question too about, 3 years post stroke, can it be helpful? And, at the center, we have seen people improve abilities over many years post stroke and post injury. So it sounds like you're both saying that acupuncture is something that could be beneficial, but even years after injury, that it could help with regaining or improving abilities.
Yeah, I mean, what I would say is it's not going to help everything. There are certain things that it may be helpful with. It's one of those things that is easy enough to try, and I think it's worth giving it a try. I just would caution you that you have to be realistic because it may not help everything. So, for certain areas such as pain or discomfort or sensory problems, it may be very helpful.
I know we're looking for that one therapy that would help everything.
Yes.
So yes, would be great if we had that. Great. Well, thank you for your responses to that question. What do you think about devices such as LPSI hand, Lipsa hand, and Tongboshi smart hand function? I'm assuming you'll know what that means, Jacki.
Actually, I haven't heard of them before, but I'm going to put them on my list to research and then I'll get back to you.
Okay, I'm going to copy. I'm going to send that question directly to you so you can see how it was spelled, because that will probably be helpful. And I'll put that in the chat for you.
There are a lot of there's a lot of new technology out with new devices for the hand. So I'm staying up to date, trying to stay up to date and use a lot of them, but I haven't heard of those yet. So I'm excited to learn.
Are there others that you're using for a smart hand function?
So a lot of what I use in treatment is electrical stimulation devices, the Bioness H200 I use a lot. And there are some newer devices that Sabo has come out with that I use pretty often. Even some that are air pressure devices to help with range of motion, but those specific ones I haven't had much experience with yet.
Mm-hmm.
Yeah, I have an interest in robotic devices and orthotic devices that can help with upper limb function. Those two I'm not familiar with, but as Jacki said, Bioness makes a device that has fairly widespread use. Sabo also makes a number of devices that can be helpful for people who have a hand function that's not optimally functioning after a stroke or a TBI. But there's constantly new things coming out. So be interested to know about the two that we just were mentioned.
Yeah, that's very exciting. And so what we'll do is we will send the response when you do a little research on that. If there's any information that you would like us to share to the person who asked the question, we'd be happy to email them. Yeah. So let me go. I just saw that I'm looking at names. So Anne Marie asked, what were the names of the devices that were in the question? So, oh, and Deborah's responding to that. Okay, great. She's typing in that response to her. Okay, great. So we'll go to the next question. And what to do? Oh, yeah. So this is a tough one, and we hear this often. What to do when they refuse therapy or medicine for their bad moods or OCD? So they get so angry and stress us. I thought about finding a separate place to live. Social worker thinks it will help better our relationship.
So right away when it comes down to behavioral issues, immediately I would say seek professional help from a neuropsychologist if possible. They would be able to help you individually with your situation. But actually, we just had inside the community a neuropsychologist come on and talk about behavior management at home. And I would definitely recommend going in, watching that recording, and viewing there's a mini course inside on behavior management. And a lot of it is explaining the importance of validating your loved one's feelings and communicating with them appropriately, providing positive reinforcement. And a big one is creating a behavior log, which inside the Empower Neuro community, I teach you how to create a behavior log. And what that means is kind of being a researcher of your loved one's behavior and creating a log of like, okay, they at this time and this date, they had this behavioral response. Were there any triggers that caused that behavioral response? What did I do in response to their behavior? And what was their reaction to me? Did they respond well and maybe calm down with the way that I responded? And it'll make more sense when you view the behavior log. But if you can kind of be a researcher in that way and keep track of it, then you can bring that to your neuropsychologist or your medical team and try to find the best treatment strategy for moving forward. But really trying to understand the triggers of the behavior and the treatment that works best when the behavior is acting out, that can give you information for taking a step in the right direction. Patricia, you're muted if you're chatting.
I'm chatting with myself, which I do often actually. But yes, thank you. I didn't realize, I forgot I muted myself. I was looking back at the question. Yeah, and so one of the things that I'm wondering about the question, it says what to do when they refuse therapy or medicine for their bad moods or OCD. When they refuse therapy or medicine. So I'm wondering if that means when if the medical practitioners are not providing the therapy or medicine, or the loved one is refusing to take the medicine or to do therapy, which I think that's what it meant, and that's what you answered, Jackie. So I'm just rereading it to ensure that we kind of captured that. Yeah.
One thing that is a really great tip that I do in therapy, because of course some of my clients also refuse therapy. And what I do if they refuse, sometimes I just do something to change up the environment or change up some type of physiological state that they're in. So it could be just going outside for fresh air. It could be putting music on. It could be washing their face with maybe some cold water, taking a shower. Like changing up their physiological state in that moment could be helpful sometimes.
We have that at the center quite often, where we have, and we serve several hundred people a year in different services, and so we see a range of challenges that people face, and sometimes it is um, realizing that somebody's tired and they're having this reaction or refusal of things because they're fatigued or they're hungry or it's too hot, or sometimes that communication or that even self-awareness of that's happening. I do just want to, I have compassion and for this person in this question, because it's also about, thought about finding a separate place to live. And sometimes, the social worker saying that might be good for their relationship. And I think sometimes like that can be a solution that is the best course for a particular situation. I do like to support what Jackie said in the beginning of the answer to that question about how to consult with a neuropsychologist or a professional who specializes in brain injury to really help think that through and what that might look like and what's going to be the best decision for you and your loved one. I think we need that kind of guidance. These are big decisions. So appreciate your time on that, Jackie. Yeah.
Not an easy situation.
No, not an easy situation. Okay, so then another question is thoughts on spasticity reduction and movement control through exercise, manual therapy, 2 years post-stroke.
Oh, I have tons of thoughts on this.
Oh boy, how much time we got?
No, I won't share them all, but what I want you to know is that it's absolutely possible. I have a client that's 8 years post-stroke and her hand was like this, and now she's like this after just like 4 months of therapy. So I just want you to know that like every human body is different, everybody's different and responds differently to therapy, but just don't lose hope, even if you're 2 years post. And again, inside the community, I can help you. I have stretching videos, weight-bearing activities that we can go over so I can help you.
Yeah, I might just jump in here for a second. Obviously, there's a common problem that I see, and I think the cornerstone of all treatment is ranging and stretching, as Jackie just said. That should be the primary treatment that's done. Often can be helpful. Sometimes it feels like you're pushing a rock up a hill and it's rolling back down again. But certainly that should be the cornerstone of treatment. For focal spasticity, medications such as botulinum toxin and variations on this that have come out can be very helpful in weakening muscles that are overactive, that are interfering with function. And while it can't be done for many different muscles in an arm and a leg, certain targeted muscles can be done. It can be very helpful. And with that, you can combine the Botox and work with an occupational therapist, for example, on an arm problem to actually facilitate function. Same thing can be done in the lower extremity, working with a physical therapist. Oral medications generally are not all that good. They're tried a lot. Sometimes the side effects make them not very usable, but they often are tried, and you've probably The asker of this question has probably heard of medications like baclofen or tizanidine or dantrolene. They can be tried. They often, as I said, may have a lot of side effects. And in some cases, using pumps to actually pump in medications into the nervous system can also help with spasticity. Bottom line is, ranging and stretching is the cornerstone of treatment, but there are a lot of other options out there to assist the therapist as they're trying to make a arm or a leg more functional.
Mm-hmm. And ranging and stretching and then splinting too, which that's where Sabo could come in as well. They have a lot of devices that help to keep you, once you stretch, to help keep you in that position so that your muscles and everything are elongated and staying there so that you don't just come right back into that flex position.
Mm-hmm.
Oh, great. Thank you. One of the questions, are the devices that you mentioned available for home use? And I think that was maybe what you mentioned a little bit ago, Jacki.
Yeah, like the Bioness, the Sabo devices. Yes, they can all be used at home. They vary in price range. But I can send you, Patricia, maybe the links to where they can find out more about them.
Okay, great. And if, yeah, that can happen when Dr. Abrams is speaking, or if you want to send it to me, and then we'll send it out to everybody who attended either way, whatever works best for you. Okay. I'm looking to see, we're getting to Dr. Abrams' time here. And it looks like one of the questions was any suggestions for 5 years post injury having spasticity. I think the two of you addressed that. Yeah.
Yes.
Okay. And then the next questions I believe will be good for Dr. Abrams when we after he shares his spiel about neurology. So Dr. Abrams is an expert in neurology and director of the Neurorehabilitation Program at UCSF Medical Center. And I'll let you tell them more about yourself, and I'll turn it over to you now.
Well, thank you, Patricia. So, as Patricia mentioned, I am a neurologist. And as you know, neurologists specialize in the diagnosis and management of diseases of the central nervous system and peripheral nervous system. Just being a neurologist, though, doesn't necessarily mean that that's perhaps helpful to people who have chronic neurologic disease. Some neurologists only deal with the first couple of hours after a neurological problem occurs. Other neurologists have certain areas where they specialize in and just are not aware of certain other areas. To be perfectly honest with you, there aren't a lot of neurologists out there who deal with chronic neurologic disease. I came about it somewhat serendipitously when I was originally on the faculty at Columbia University in New York, and I became involved with a rehabilitation hospital that was associated with Columbia. And as a result of that, I became familiar with a lot of the issues that are associated with people dealing with acquired neurologic injuries. So neurologists can be helpful for some very specific things. They may not be helpful for every problem that a person with chronic neurological disease is dealing with. But hopefully, if you have a physician who's working with you who wants to be helpful and wants to help you locate the right kind of specialist to deal with your loved one, you'll be able to find, at least for a neurologist, the one that can work with you on a long-term basis. So what I was going to talk about today is basically almost supporting the idea of how caregivers deal with the issues that they have to deal with. And I thought I just would start off with a couple of slides that talk a little bit about how the medical literature looks at the problems of caregivers. Let me share my screen here. And I hope everybody can see that. And there are obviously lots of chronic neurologic diseases that caregivers have to deal with. The ones that are dealt with at the Schurig Center are mostly acquired neurologic diseases. So the Schurig Center doesn't typically deal with patients with Alzheimer's disease, for example, which presents a huge challenge for caregivers, but is not something that we deal with a lot at the Schurig Center. I thought I'd talk about a couple of the diseases that we do deal with perhaps on a more frequent basis, and Parkinson's disease is one of them. Parkinson's disease is actually a disease that is a disease by itself, and then there are multiple other diseases known as atypical Parkinson's disease or Parkinsonism that have features of Parkinson's disease, but are not, have different responses and are treated in different fashions, and unfortunately, often have worse prognoses than Parkinson's disease itself. The caregiver burden here can be huge. It includes impaired mobility and cognitive behavioral symptoms. But in the atypical Parkinson's problems, there are blood pressure problems that can lead to problems with fainting. There can be problems with bladder control. There can be problems with sleep issues. The caregiver burden in Parkinson's disease actually increases as the disease progresses. And therefore, as a caregiver, you have to be prepared to unfortunately deal with more problems as the person ages and has this disease for a longer period of time. Now, with Parkinson's disease itself, life expectancy is only mildly reduced. However, in the atypical Parkinson's syndrome disorders, life expectancy can be markedly shortened. And again, that's something the caregiver needs to take into account when coming up with a plan and viewing the overall outlook for somebody with Parkinson's disease. TBI and stroke are probably the two things that we deal with the most at the Schurig Center. They're different than a disease like Parkinson's disease or a disease like Alzheimer's disease because these problems occur suddenly and they often require an acute need for observation. So with some of the more some of the other neurodegenerative diseases, the onset is slow and the progression is relatively slow. With TBI and stroke, the onset is dramatic, sudden, and therefore one can become a caregiver overnight without much preparation or time to actually think about what's needed to be done to be a caregiver. Medications can be effective in avoiding or reducing dependence, and it's important to work with a physician, a neurologist, or a physiatrist who is familiar with the medications that are most important in the management of TBI and stroke, and therefore can help you as a caregiver help your loved one. Comprehensive rehabilitation is crucial for partial or even full functional recovery. I can't emphasize enough how important rehabilitation can be and the contact that you get with rehabilitation specialists in terms of maximizing or optimizing recovery. Unfortunately, it's not always available. And sometimes when it is available, it's rather costly. But to try and access and to comprehensive rehabilitation for TBI and stroke is critical in terms of getting the best outcomes. So there are some common features of caregiver burden that make things tougher. So the older the patient is, the men seem to have more problematic than, say, women. Obesity, but obesity and the BMI can be influential on how big a problem there is. There are impairments, obviously, in mobility and ADLs, and cognitive behavioral abnormalities are also important factors in caregiver burden. The more of these you have, the bigger the burden is. And one needs help in dealing with these things if one is going to actually reduce some of the burden. I think Nowadays, video consultations can be especially helpful for patients with stable disease. And these are not necessarily video telehealth consultations with just physicians, but you could have video consultations with rehabilitation specialists. These things can be used to actually design or modify rehab programs. They can be helpful with medication management. So I think it's advisable for caregivers to try and work with a physician or neurologist who is open to video consultations and is open to actually doing not daily video consultations, but certainly frequent video consultations to help you deal with the ongoing problems that you may be experiencing. Caregiver burden also depends on a lot of personal factors of the caregiver. So things like socioeconomic factors are crucial in terms of how much stress is going to be put on the caregiver. Personal competencies of the caregiver will also be important to determining how much stress there will be in caregiving. And the medical system supports are also important. Some countries, the medical system supports for chronic neurological problems are quite strong. In the US, I would, unfortunately, some of these systems are not all that strong, although there is activity afoot to actually make disorders like TBI and stroke more of a longitudinal problem that will be supported by the medical system on a long-term basis rather than most of the acute basis where a lot of the medical attention goes to. So what can be done to help reduce caregiver burden? Well, certainly, as Jacki has pointed out, professional support is very important, and hopefully for a lot of people, family can be a very important support system. You have to make time for leisure activities. Caregivers have to maintain social contacts. They have to deal with their occupational problems. These breaks in caregiving are truly crucial to reducing caregiver burden. One thing that I was interested in, I think it could be important, are holidays for both the patient and the caregiver. I was interested a couple of years ago to find out that there are cruises that families and patients with aphasia can take, in which there are other families and patients with aphasia cruising. These kinds of holidays can also be, I think, important in terms of reducing caregiver burden. And finally, the caregiver burden is lower in close-knit families where there is an understanding of the caregiver needs. As a neurologist, I think it's important for me to be aware of all these issues to reduce caregiver burden. These are not necessarily always medical problems, but certainly as a neurologist dealing with chronic neurological problems such as TBI or stroke, I always want to be aware of the problems and the challenges and the great job that most caregivers do helping our patients that have these various types of problems. So I think I would stop there, and I would like to entertain any questions that you have. I can give you, if there's specific questions about specific neurological problems, I'll have to be a little cautious about giving you absolute answers, but I certainly would be open to giving you a kind of off-the-cuff opinions and trying to point you in the right direction to get your questions answered and to get the appropriate assistance for your loved ones.
Okay, great. Thank you, Dr. Abrams. So to look at some of the questions, I have heard a lot about Dr. Mickey Collins at the University of Pittsburgh Medical Center Concussion Clinic, particularly for people that have had post-concussion symptoms. What are your thoughts about this?
Very good center, has a terrific program in traumatic brain injury. The things that they do here are frankly duplicated in the Bay Area, but I think it's an excellent program, a very well-known program. And if you have the opportunity to access that program, I would highly recommend it.
Oh, that's great. And are there programs locally? You said in the Bay Area?
Yes, well,
Know of?
at UCSF, we have a neuro recovery clinic.
Mm-hmm.
And this is a clinic that deals with the problems that we've been talking about thus far in the webinar, and certainly deals with many patients with post-concussion syndrome. This particular clinic has a special clinic for post-TBI, which not only has neurologists involved in treatment at the clinic, but also the neurosurgeons at UCSF. So people such as Dr. Jeff Manley and his group participate in this clinic, again, specializing in traumatic brain injury problems. For other kinds of neurological problems, stroke, spinal cord injury, the general clinic will help in that particular area.
Okay, great. And just to also remind and share that we have a resource referral program where we help to do the legwork to find resources that people might need in the community. We also look outside of the area. So we have a concussion information sheet if anybody wants to reach out and is interested in getting that kind of information too. Can you recommend a neurologist? Oh, no, it's not a neurologist. Sorry. Can you recommend a neurologist at UCSF? If it was a neurologist, you'd recommend yourself, I'm assuming. So I'm going to be like, well.
Well, I'd recommend one of my colleagues.
Yeah. But this is a neurologist.
Yes, Dr. Ann Suskind, I've worked with over the years. I think she's very good.
Oh, let's type that into the chat.
It's Susskind. And
Susskind. Okay.
yeah. And many of my patients have worked with her, both for treatment in many different ways for various kinds of bladder problems that may be associated with problems such as TBI or stroke or spinal cord injury.
Okay, great. So I just put that in the chat. Oh, and in fact, Deborah put the actual link. You go, Deborah. She's the Oz behind the curtain, and she's amazing. Okay, great. So I also wanted to just share that farther up in the chat a little bit while Dr. Abrams was speaking, Jackie went ahead and put links to some of the products or the equipment that she had been mentioned earlier. So there's a link to the Bioness devices and Sabo devices. So for anybody who is interested in that, I just want you to know it's in the chat. There's links. Okay, great. So the next question, hemorrhage stroke 10 years ago, seizures for the first few years, currently on lamotrigine?
Lamotrigine.
Lamotrigine, okay. 500 milligrams a day. No seizures that I'm aware of the last few years. Any hope that he could get off the anti-seizure medications?
The answer to that question is basically a yes. So when somebody has seizures that has been seizure-free for 2 or so years, you can start the discussion about possibly discontinuing medications. There are problems, though. For example, if somebody is driving and has been on these medications for years and has gotten their driver's license back, one would not want another seizure to occur in which not only would injury be possible, but where the person might lose their driver's license. If you stop the medication or taper the medication, there is a risk of having a seizure again. There's no question about that. However, one has to weigh the value of keeping the medications on and the downside of keeping the medications on versus the upside of getting rid of the medications. This would require a discussion with, I would think, with an epileptologist. Who's an epileptologist? An epileptologist is a neurologist who specializes in the treatment of epilepsy. They can be found at comprehensive epilepsy centers at UCSF, at Sutter Health, at Stanford. There are a number of different excellent epilepsy centers in the Bay Area. And I would start having a discussion with their treating neurologist. But if you're not certain that you're getting the right answer or there's some question about what should be done, I would recommend having a discussion with an epilepsy specialist at one of the comprehensive epilepsy centers in the Bay Area.
Okay, great. Thank you for that response. So there's a question, let's see, Deborah, I'll leave that question in there so I can come back to it after Dr. Abrams. So the next question, curious about experience with baclofen pumps, general helpfulness, and whether there are negative effects, especially negative effects in relation to the nervous system and the body improving its ability to produce movement. Thank you, exclamation mark.
Yes. So baclofen pumps were introduced, been around quite a while now. And what a baclofen pump is a pump that actually delivers baclofen into the spinal fluid around the spinal cord. The baclofen then can diffuse in the cerebral spinal fluid and get to places that it's necessary to work. Why use the pump? Well, baclofen comes in an oral medication, but in order to get the best effect, you have to use so much of the oral medication that you start to get adverse effects. When you use when a baclofen pump is used, you can use very minute doses of baclofen to get a desired effect and therefore obviate a lot of the effects of the baclofen going places that you really don't want it to go. Now, can it be helpful? Yes, it could be very helpful for some people. Will it be helpful for everybody? No. It can be particularly helpful in terms of allowing people to get better function of an arm or a leg so that they could then perhaps work with a therapist to actually really improve their overall function. How do we know who's going to be a candidate? Well, what happens is people who do these baclofen pumps will do test doses. And what they do is you'll have a spinal tap and a certain amount of baclofen will be injected into the spinal fluid. Then the person looks at the function that you're trying to treat to see whether the baclofen in the spinal fluid was actually helpful or not. If it is helpful, then one can go ahead and put a pump in which is entirely internalized so that the person actually has a little machine, it's a hockey puck that actually sits in the lower part of the abdomen and pumps in baclofen on a regular basis. The amount of baclofen that's delivered can be managed by an external device that actually can decide how much baclofen will be given at any particular time of day or how fast the baclofen should be infused. So it is helpful. The adverse effects of it can be related, for example, pump problems. So it could be a hardware problem. The hardware has gotten very good over recent years. And so I think that has been less of a problem, certainly in the last decade. There was a second part to that question that I don't want to miss. Could you just repeat that? The adverse had something to do with negative effects? You're on mute. I'm sorry.
Yes, thank you. I just scrolled back to the question. Curious about the experience, especially negative effects in relation to the nervous system and the body improving its ability to produce movement.
Yeah. Sometimes the intrathecal baclofen can be too potent, if you will, and actually inhibit function. But that's the reason why we do these test doses. If a test dose is positive, it may not perfectly address the problem, but you can then titrate the baclofen with the pump to get the desired effect. So the answer to the question is yes, it can cause problems, but we're aware of these problems, and there are methods to actually try and get the best possible response from the intrathecal baclofen. Just one final thing, I think it could be very useful in certain situations. particularly with people, for example, who have spasticity that's actually inhibiting their use of underlying good muscle function that they have.
Great. Thank you, Dr. Abrams. So the next question, are there any exercises or treatment for peripheral double vision after surgery has corrected direct vision? This is following TBI 3 years out.
Let's see. I want to make sure I understand this. This is somebody who has double vision, who has had surgery to try and correct the double vision, but the surgery was not effective. Is that the question?
I'm not 100% sure. It says, are there any exercises or treatment for peripheral double vision
Yes.
after surgery has corrected direct vision?
I'm sorry, I'm not quite understanding that. There are, for example, prisms that can be used to help correct. So, in other words, prisms that go into corrective lenses that can actually help to correct vision non-surgically. Um, again, it depends on the particular problem, so I hesitate to give you a direct answer on that. What I would suggest is that if you do have a question about it, that you consult with a neuro-ophthalmologist. And
Absolutely.
a neuro-ophthalmologist should be able to answer these questions either and recommend a way to go with treatment.
Absolutely. We have clients who are reaching out for neuro-ophthalmologists for these particular instances. And I believe we have some resources for local and maybe beyond. So if that person would like to reach out to us, we can see if we can find referrals for that.
Absolutely.
Yeah. Okay, so what is going on in the medical education sphere to increase the number of PM&R doctors? What is being done to include teaching on TBI and other acquired brain injury in medical schools?
Okay. Well, this is an interesting question. So, there is a shortage of doctors in this country, and it's getting worse. PM&R is a relatively small specialty, and there are not really all that many residency programs that train PM&R doctors. In the Bay Area, for example, Stanford has a residency program, but UCSF does not. And the issue of setting up training programs for any specialty, whether it be PM&R or cardiology, are very complicated. You need faculty, it requires a lot of money, it requires space. So there's a limited amount that can be done on a short-term basis to increase any medical specialty. In terms of training in the medical schools, medical schools, there is so much to learn and there's so little time to fit everything in. People are constantly fighting, that is faculty, fighting to get their share of the medical students to tell them about their particular specialty or their particular issues. I think there is not enough education in medical schools on chronic problems and chronic neurological problems such as TBI. I think there's a recognition of this. And it's not that people want to ignore this. It's a matter of trying to fit it into the curriculum. However, as I said, there's not a lack of awareness that we need to know more about how to manage chronic neurological problems, particularly as our population ages. Forget injuries, just the aging of the population requires this on the part of medical schools. So I can't speak for medical schools. I agree with what you're trying to get at in your question, but it's a complicated problem.
It is, and we're hearing more and more that there's even fewer physicians available. And I was just visiting in Iceland and heard that from family there as well, that their healthcare system is changing as well. So this seems to be a true challenge. But I really appreciate that question too. It's an important one. This may, or I'm not sure if this is a question exactly, but it says, we are in Kaiser. tried to change last year during open enrollment, but could not get a primary care physician at UCSF. So it may have been a comment more than a question.
Yes, yes. Finding primary care, I just don't want to blame UCSF. Finding primary care physicians in any system has become challenging. I will say this, though. UCSF is on the move to hire many more primary care physicians. I was at a meeting, I was at a meeting just recently where I think there have been 26 new primary care physicians that are in the process of being added, and they're going to be more. So it is a big problem. I'm not going to apologize for, I don't speak for UCSF.
I thought you represented the entire institution.
But it is a problem. And even when I try and get patients that I'm seeing at UCSF to try and get them primary care physicians, it can be very difficult. So it's
Absolutely.
a situation. But it is going to improve.
Great. We look forward to that. Next question. Any suggestions for brain fog and fatigue that happens about midday and really keeps husband from life, i.e. time with family or activities? He reports this to be his main issue after stroke.
Yeah, this whole concept of brain fog is something that has become really talked about in the literature. It wasn't just it's very commonly seen after TBI, but it's also been a problem with long COVID, which we haven't really discussed at all today. You have to think of the brain as a complicated network of neurons that talk to each other. And when they don't fire together in the appropriate fashion, you can get something called brain fog, particularly when it impairs certain areas of the brain. How to deal with it is not easy. We sometimes will try medications, and there are some medications in the stimulant category that have been helpful in some individuals. Certainly, exercise can be extremely helpful in terms of helping the brain deal with brain fog. Most people think of exercise as cardiac or pulmonary, but the way exercises has huge effects on the brain. So exercise can often be something that can be helpful. Um, it's hard to know what the issue is with your specific with your specific loved one, but I do think it's worth a discussion with a neurologist or neuro recovery specialist in terms of what might be done for brain fog and what kind of medications and/or therapists could be helpful in terms of relieving some of this problem.
Could a neuropsychologist be helpful in working with, or even somebody like Jacki, in working with how to manage a schedule so that maybe there's a change of schedule, so by the afternoon there isn't as much of that fatigue, so kind of titrating throughout the day, or mini power naps, or things that, in addition to what you shared as well.
Energy conservation and energy management are core problems for occupational therapists. So yeah,
Okay, great.
Somebody like Jacki could be very helpful, and a neuropsychologist could take a look at the overall picture, the overall cognitive picture of the individual, and suggest where certain things might be helpful in turn, where the deficits are, where the strengths are, and how do you use these things to get the best possible response.
Jacki came back. I think she,
I
this
think,
is a good question for me.
yeah.
I mean, but just like Dr. Abrams mentioned, I would just suggest trying to analyze a little bit of your routine. There might be certain activities that are causing more brain fog than others, or more fatigue than others. Trying to really analyze when the brain fog comes, or again, like being your own researcher, just like with the behavior problems, trying to figure out if there's some cognitive task that is causing more fatigue. That could be something, or you're eating, right? So yeah, just I would say maybe journal out what you're doing throughout the day and try to keep track of it, figure out maybe what could be causing it. And then I'm happy to help with energy conservation techniques as well.
There's great advice. I would suggest, as I said, perhaps getting a neuropsychologist to get a profile of what the problems are, making observations, as Jacki pointed out, and then sitting down and working out a plan about how to attack this brain fog. As I said, maybe medicines, it may be exercise, it may be learning. You just have to see what comes out in the wash.
And Jacki, this is kind of up your alley for consultations, so people can hire you to come to their home and help with something like this, even if it's a consultation or a one-time
I'm happy to help.
assessment work together. Yeah. Um, Thoughts on etanercept, Enbrel, being used for brain injury? I'm not sure if I said that correctly. Seemingly being used in places, but isn't widely accepted or recommended. Thank you.
I would have to say that it's not widely accepted or recommended. There was people have talked about trying to. Enbrel is a biologic that helps with inflammation. That's kind of a simplistic thing, but can help in terms of reducing inflammation. I don't think it has a role in the treatment of brain injury at this point. So it would be very off-label. And certainly we use medications that are off-label to address problems. But that would be a little bit out there from my perspective.
Okay. Okay, thank you. Thank you for your response. Any acute program at UCSF for stroke if we are willing to pay ourselves?
I presume you mean acute rehabilitation. I'm not any for acute. Well, I need some clarification there.
Okay, so I'm going to go ahead and ask the person with that question to post a little more clarification in the Q&A, and
Okay.
then we'll come back to it.
Good.
Okay, great. How can a person following TBI improve the ability to multitask? Oh, Jacki, hop back on. How can a person following TBI improve the ability to multitask or hold more than one idea in the mind at the same time? This is 3 years out post-injury.
Yeah, I'll start with that, and Jacki can follow
I
me.
felt like this would be both of you.
Yeah. So cognitive rehabilitation can be effective. And cognitive rehabilitation is practiced generally by, well, I was going to say speech and language pathologists, but also occupational therapists. For example, we have a cognitive rehabilitation program that we've been worked with for many years at the San Francisco VA and veterans with traumatic brain injury and problems such as you just bringing up here. It can be very helpful. Again, it depends on the depth of the problem and the types of the problem, but I would certainly think that it's worth consulting with either an OT interested in cognitive rehabilitation or a speech pathologist who interested in cognitive rehabilitation and doing cognitive rehabilitation to see if they can help you with that particular type of problem. Jacki?
Yeah, I agree. It depends on how severe it is. But one thing that could be helpful that you can maybe take away from this now is, again, OTs kind of focus on breaking down the task, right? Breaking down the activity. So if you're trying to learn how to maybe improve your multitasking abilities, start with maybe something that's just a little bit easier. So maybe not multitasking, like if you're trying to cook, but you're stirring the pot and reading the recipe and putting something in the oven, right? There's a lot of tasks that you're trying to multitask. So what I would suggest is just trying to start off a little bit smaller and try to multitask maybe 2 light things, make it a little bit easier, and then build your way up. But of course, I would definitely recommend seeing a speech therapist or an OT that specializes in it.
Okay, great. So we have 9 minutes left, and I think we're pretty good with the questions. I think we'll be ending on time. So let's see. I asked, did I ask you the question? It feels like I did. If there was the acute rehab. She came back with rehab after a few years. So it's programs seem to exist in other parts of the country. So is there any acute rehab after a few years? a program at UCSF for stroke if we are willing to pay ourselves?
I guess the answer for that is no. There really isn't. There currently, I won't tell you what the future may hold, but currently there really isn't a program there. If many programs do not do rehab after a certain period of time. If you're willing to pay for a program, the Center for Neuroskills, called CNS, which is located in Emeryville, has a really excellent program that I often recommend. And you can discuss with them, but it'll probably be self-pay. But I think they're a good program. I don't think that they will accept you into the program or accept your loved one into the program unless they felt that they could make some progress.
Absolutely.
And
And
too,
oh,
of course,
yeah.
my private practice, if you're only looking for OT, we don't have PT or speech, but we have a team of therapists that cover the entire Bay Area. So I'm only in one location, but we have somebody in SF, somebody in Marin, somebody Walnut Creek. We have brain injury and stroke specialists all over. So of course, if you're interested in OT services, that could be an option for you.
Oh, absolutely, absolutely. I'm sorry I didn't mention that. We also at Schurig Center, one of our goals, because when I heard the question, I was thinking it would also depend on what kind of therapies they're looking for and what kind of services. So CNS, Jackie at Holistic Life Skills, Schurig Center, we have some services working with a speech therapist. She also has private practice. There's aphasia classes, some of the classes that we offer. So there's a range, but if it was more medically based treatment specific to what UCSF might offer, that sounds like that would be CNS or maybe Jackie. And
Yeah, I'm not saying it really depends on the goal. So I always look at all rehabilitation as goals. What you're trying to do is achieve goals, and depending on what goal that you're trying to achieve, that will put you in the direction of what kind of professional you want to seek to help you.
hmm absolutely. A few more questions. What effects does medical grade, the hyperbaric oxygen therapy have on brain healing after stroke or TBI?
Yes, so there were some anecdotal reports several years ago about the benefit of hyperbaric oxygen in TBI. There was never there was never very good evidence. There still isn't very good evidence that it's helpful. The VA has been interested in it. It has a study. I don't believe it's been published as yet. My feeling is I don't recommend it. It's expensive. I think that I don't think it's necessarily harmful, but I think that the evidence that it's helpful is really weak. And so, as I said, I don't recommend it for my patients.
Okay. Okay, Jackie, I wasn't sure. Okay. I want to point out before we get to the last few questions that there are links in the chat. So before you hop off, there's links in the chat if you're interested. Jackie put the link to her Holistic Life Skills organization, so you can visit that if you're interested in checking out and working with her. We also have put the links farther up to the Empowered Neuro online program that she has put together, the community. And Schurig Center has partnered with Jackie to offer that for free to Schurig Center community. So if you use that link, yeah, so it's so that's an offer for you. So that's farther up. And we also have some other links that Jackie had put for some of the products she had mentioned. And we also have links for events coming up, which is our bocce and the art show and Schurig Center events. So those are in the chat, just to remind you. There are a couple questions in the chat, so let me just find that. Oh, we also have the link for the neurologist there. Okay, somebody asked, can you recommend a neuropsychologist and or neurologist in Southern California in the Ventura area, even in LA? I don't know that either of you can off the top of your head, that's something that I could certainly have our resource specialist look into for this person as well.
Might in Los Angeles, there's the California Rehab Institute, which is a joint venture between UCLA and Cedars-Sinai Medical Center. It's a large rehabilitation institute there, and perhaps we could get the link for there. They would have the kinds of services that I think you're seeking.
Okay, let's see. Deborah, are you on that? She is. She's awesome. Okay. Then let's see. The next, my husband had an anoxic brain injury due to an MI and is 12 years post. He has balance issues and shuffles when he walks. And so they said it was Parkinsonism. Parkinsonism. Is this Parkinsonism you were referring to? Is that what you were referring to earlier?
Um, yes, it's Parkinsonism with a small p. There are a number of circuits in the brain that are important for walking. And with an anoxic brain injury, one can get damage, unfortunately, all over the brain. So in a sense, it is Parkinsonism, but not Parkinson's disease. Perhaps I don't want to go into details, but there's certain medications that will help Parkinson's disease, but may not help Parkinsonism. In this particular case, I think the medications probably would not help. However, therapy, I don't know how much therapy has, how aggressive the therapy has been. It's practice, 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 as Jacki said in her opening remarks. The more you do something, the better you'll get at it. And I don't know whether it will help your husband, but I think one should certainly consider consulting with a physiatrist or a physical therapist or a neurologist about what might be able to be done to actually improve your husband's walking ability with therapy, therapy alone.
Mhm.
Yeah, I would highly suggest seeking out some therapy. Immediately what comes to my mind was balance exercises, of course, can help. OTs can do a little bit of that as well. And if he's having some balance issues, I would definitely, inside the community, I would look at the home safety checklist and some fall prevention strategies. Because if he is having some balance issues, then falls could be a really big concern. And that's like the leading cause of brain injury. So we want to make sure that you're just making sure he's safe in mobilizing around the home and the community too.
That was great feedback. So I think we got all the questions except one, which I'll address. In the chat, there's a link for the Empowered Neuro link for Schurig Center community to have access for free. It's right at the bottom now, so it's not, Deborah very thoughtfully put it all at the bottom. And upcoming events for our organization and the California Rehab Institute link as well. And so I wanted to, I'm going to address one quick question that was asked specifically to Schurig Center. What is the Schurig Center view on non-allopathic approaches? And so that question, so we don't have a formal view on any type of treatment or modality because we're kind of like Switzerland that way. Our organization is partnered with so many different healthcare agencies and we're non-medical facility. So we don't have formal opinions that we voice. But with that said, several of the services that we offer are non-allopathic approaches. And so just to clarify for people listening, non-allopathic is a term used to describe medical practices that are not conventional medicine. So some examples, alternative medical systems, mind-body interventions, the acupuncture, for example, manipulative and body-based methods. And so there's a whole array: homeopathy, massage, acupuncture, tai chi. Some of the things that we offer here, we have a adapted yoga movement program. We have expressive art therapy. So some of the things that we actually do at the organization are non-allopathic. And we believe in looking at the whole person and looking at the emotional, psychological, physical, social, all the different areas in somebody's life. And while our center doesn't address all those areas, we try to partner with other organizations so we can each be filling a piece of that puzzle. So we do support all kinds of, believe in different types of approaches. And I think that any type of approach can be helpful for some people, and it's always worth exploring. Oh, yes, I can. Can I plug the caregiver support group? Yes, I can. Thank you for bringing that up. So we have a support group for caregivers. It is twice a month. So we have a peer-led support group that is on the second Saturday of the month. And it is from 10:30 to 12. It's on Zoom. Then we have a professionally led support group by a neuropsychologist. And that is, I believe it's the fourth Saturday or the last Saturday of the month. And we send out reminders, and it's free. And you just click on the link. You don't have to register. You can just join the Zoom if you'd like. So if you are a caregiver who would like to consider joining our support group, all you have to do is post your email in the chat, and we will add you to our list, and you'll get the announcements for it. And it's a very wonderful group led by people who genuinely and deeply care, and have experience in the area of brain injury personally and professionally. So the other thing is that this is recorded. Most of it got recorded. We lost the first, I think, 15 minutes, but the rest of it's recorded. And it will be on our website, and we will send out the link. And it will be, you can go to our website and watch the recording from there. The next caregiver support group is this Saturday, in the peer-led one. So if anybody's interested in getting on for this Saturday, just put your email in the chat. And then I also wanted to remind you the next date for our next speaker series is October 3rd. So look out for an announcement of that group, who the speaker is, and the timing. I'd also love to ask you to please stay on after we close out to answer a few questions that will help us create a speaker series that is a really good fit for you. So the questions have to do with what speakers would you like? What topics would you like? Do you want this on Zoom or in person? Did the format of this event work for you? This is our first one, so we really want to get your feedback. Would you like to receive more information about Schurig Center and holistic life skill services? And are there other events and services you would like to see available for you or your loved one? So that would be great if you could just stay and take 3 minutes and answer those questions for us. So we close the webinar, and then you will see the survey come up for you to answer. We have a thank you to all three of us. You wonders. Great content and wholehearted helpfulness is much appreciated. Oh, thank you for sharing that. We really appreciate the feedback. We are here for you. So hoping that is what everybody feels. There is a question about how to copy all the links that are posted. That's a good question. It looks like, well, you can click directly on them, and it'll open your web browser to those pages. If you want to copy them, I just highlighted it with my cursor, and then you can copy and paste, I think. But yes, so you probably want to try that before we close out of the webinar. Deborah, when we close out of the webinar, the chat is gone, right? Oh, okay. Deborah said that she is going to send all of the links to anybody who attended, and you're going to receive a thank you email, and you'll get the links and some of the resources we shared too. Oh, this is wonderful. I'm just so grateful for Deborah and knowing how to do all this. Okay, great. So it looks like we have addressed everything. So we have a couple of people, Deborah, who put their emails in the chat who want to be added to the caregiver list. So if you could grab those, that would be great. And I guess that's pretty much it. This has been a wonderful first experience. I can't thank you enough, Dr. Abrams and Jacki, for sharing your passion, because you're clearly passionate about what you do, but also your expertise and your time. And also for all of you who showed up and attended. Really appreciate you being here. All right, so we're going to close out, and if you could do the survey, we would love it. Let's see, there's something in the Q&A. Okay, got it. All right. Have a good night, everyone.
Everybody.
Mhm.
Okay.